to Linda Hassenauer for being with us today. I want to introduce her. She's a physical therapist. She specializes in many things, but she has owned her own practice for over 13 years in Enumclaw, Washington. At Family Physical Therapy, she specializes in women's health and helping them live their best lives. After her second child, Linda saw the needs of her clients and made this her focus. She graduated from Simmons College and enjoys her book club, wine tasting, hiking, and biking. And a little story behind Linda is I did a cold call. I had a classmate from high school that told me that Linda basically saved her life. And I was like, really? And she said, if you do another Doc is in series, you need to have Linda come on. She said, she changed my life. And so when she told me that, I did a cold call to Linda. I just picked up the phone, found her business phone number, called her and said, hi, Linda, my name is Yes. And she's like, okay. And over time, she joined my menopause group and trusted me enough to come on and do this series for us. So I want everyone to give her, come off mute really quick and give her a round of applause for being here today. Yay!
Thank you.
All right. Thank you very much, and take it away.
All right. So, yes, I'm Linda, and I'm in the little town of Enumclaw. We've lived here for 20, almost 23 years, maybe. I worked in another clinic for a while, and then I opened my own. And I do specialize in pelvic health. That's mostly what I do, and I see almost all women. Really, the only men I see are the spouses of my patients that my patients will say, my husband hurt himself, can you see him? And I'll go ahead and see him, especially if it's somebody that I know pretty well. But otherwise, it's mostly pelvic health. And yeah, I graduated from Simmons College, which is in Boston. So it's kind of the other side of the world from here. Let's see. My family is probably the biggest reason I do this. And yes, my second son was over 9 pounds, so he was big enough. Here is my Y, if I can get it up there. Show you all my kids, including my newer one, which would be my son-in-law. I gave birth to 2, and then they were 8.5 and 9.5, and I had ruined my body enough, so we adopted the third one. We went to India, and he was only 3 pounds at birth, so that was the easiest delivery for me. Fly on an airplane, go pick him up, and bring him back. My daughter, the wedding picture was 2 years ago. She now, instead of having a bouquet of flowers in front of her belly, there's a little baby in there. I'm going to be grandma for the first time in the spring, so I'm pretty excited. I think that kind of sums up me, and I think Diesta said why I was doing this. We lived in southern Idaho, very conservative town, and I had a really hard time getting pelvic floor work approved by the doctors. They thought they knew more than I did, although I look at things from a completely different perspective than what the doctors do. I don't use a speculum. I am looking at muscle tone, and that's kind of how I am treating things. The doctors are looking for disease. So I thought I would start off just kind of giving you some basic anatomy information. Most of us know, we know what our hands look like, we know what our face looks like, but we really don't know much about our pelvis and our pelvic floor. So this is Mabel. And I use Mabel all day long to help my patients. This is your pelvis, your pubic bones in the front, the pelvic bones, your spine, your sacrum attaches to your spine, which attaches to your pelvis back here. These are some of the ligaments that show that. Then there's all your pelvic floor muscles. So the pelvic floor is made up of at least 8 muscles that are in 3 different layers. So it goes deeper, from superficial to deeper. The muscles are all in different directions, doing different things. Most of the muscles meet at this spot right here, which is called your perineal body. And that's where you can see they meet from there, they meet from here. If you have a baby and you have either an episiotomy or you tear, this is where you tear. Here's your vagina, and often you tear straight back toward the rectum, or maybe a little bit off to the side, whether it's a tear or a cut. So if you've torn or cut right where the muscles all meet, the doctors aren't going to line up the layers of the muscles afterward. They're going to put it together and they're going to stitch it up. So that's often why there's then weakness of the pelvic floor afterward if you've given birth. Even if you have a C-section, you could well have weakness of the pelvic floor because you've got a large baby and everything else that goes with it, putting all their weight on this small group of muscles. Does that make sense to everybody? Anybody have a specific question related to that at all? I don't see any. Okay. Behind the pubic bones sits the bladder. It's right back there, and it needs to be able to move. Behind the bladder, kind of behind and on top of the bladder, is the uterus. So the uterus we all kind of got when we had our education on this back in school. We were taught the uterus sort of sits up like this with the tubes going out to the side and the ovaries out there. The reality is the uterus sits forward like this, and the tubes kind of head back with the ovaries. I don't know if you can see my hands, ovaries back here. Some women have a tilted uterus, and it can be either tilted further forward or a little bit backward, but it doesn't sit up nice and upright. As the uterus grows, if you are pregnant, the uterus is going to grow in the body, and it's going to move all the other organs that are there. It's going to move the bladder down closer to those pubic bones, so that if you have to pee a lot when you're pregnant, it's because there's about this much room between a full baby and your pubic bones, and it's just getting smushed. So there's not much room there. The diaphragm has to move up as you get more pregnant. The stomach gets squished. All the organs do. The intestines, everything just gets moved around. And it doesn't affect you just during your pregnancy. Often after pregnancy, after menopause, which is why I'm mentioning all this, some of those changes can still take effect. There can be inflammation in the body from the uterus getting bigger. It can inflame the bladder, the intestines, anything that it's smushing, it can cause a reaction in. If you have a C-section, the C-section afterward is not going to impact just the uterus. Think about the layers that you have to cut of muscle to get down to the uterus. And then after they've opened it up, taken your baby out, then that is going to cause a scar. And that scar can grow in all different directions. And it's going to keep growing until it can attach to something and kind of solidify. Scars can have blood flow, nerve flow, all of that. So years later, those scars can cause all sorts of problems. And that's what I do a lot of treatment of. I think that's kind of enough about the scars. So one of the things that the bladder does in the body, pregnancy or not, well, mostly not, is as it fills up, as it fills with urine, it raises up in the pelvis. So as it comes up higher in the pelvis, it can hold more. Well, back to scars, if there's a scar or an inflammation or something that's pushing down on that bladder, it can't raise up and fill. It can only fill a little bit. So that can be one of the contributing factors to pelvic floor and bladder control issues. As the bladder fills up, it needs to be able to move the uterus kind of out of the way. And again, if there isn't movement between those two things, which I guess I haven't mentioned. So any of your organs, as you're moving around, the organs have to slip and slide between each other. If there isn't that slip and slide between them, then you're going to have problems. So the organs need to be mobile, but then they also need to be somewhat stable. There are ligaments that are attaching, especially to the uterus, in all different directions. Your uterus, there's ligaments that attach it to your back. There's ligaments that attach it to the side walls, so that as the baby's growing, it's not just completely flopping around, there's some stability to it. If there's too much stability or too much mobility, either one can cause problems. There's kind of a nice balance that needs to happen for uterus and bladder and all of your organs to function correctly. Does that all make sense to everybody? Kind of a quick and dirty anatomy lesson.
Yes, that's helpful.
Good. Okay. And I guess if people want to unmute and ask me questions, that would be easier than having to read it if somebody does have a question. So feel free to ask. So now to apply that to what we want to talk about, which is menopause and the issues that can happen with that. So with menopause, one of the things that happens before menopause, we're producing more estrogen. Cyclically, monthly, we produce more estrogen, a little bit at mid-cycle when we ovulate, and then more when we are about to have our period. And the increase in estrogen is for the body to prepare to either discharge the egg during ovulation or to prepare for pregnancy in case we are pregnant. Every month, our body's ready for us to be pregnant until we hit menopause. That extra estrogen, one of the things it does is provide blood flow to the pelvic floor. So if when you were younger, you looked at your pelvic floor, it might not have been this red, but it was probably fairly dark pink. Postmenopausal, if you look at your pelvic floor, it's probably a much paler pink. Almost, well, not quite skin tone, but it's a lighter pink.
I think mine is gray. I'm just saying.
Well, it's a different, and again, depending on what your skin tone is, it's going to be a different color. But it probably used to be a lot redder, right?
I'm just being funny because, man, everything's so dry down there. I think it is gray. All right, never mind.
Okay. So not only so that when there's more blood flow to those muscles and there's darker red coloring, there's also more moisture. So leads right up to, yes, you definitely dry out more postmenopausal because there's just not the same blood flow to that area. So it's not just that maybe we use it less, that it's dry and doesn't get the blood flow. It's physiologically, we actually have less blood flow postmenopause because we don't have that extra estrogen in our bodies. So if we're having bladder control issues, if we're looking, that's the first thing I'm going to talk about is bladder, or the second, because I talked about anatomy, bladder control issues called incontinence. There's two major causes for incontinence. People always think just they need to do Kegels. But as I kind of have talked about with anatomy, yes, there's the support from below. And if we don't have that strength of the pelvic floor, that can cause bladder control issues. But also if there's scars, that's going to push down. And the scars can be from all sorts of things, any abdominal surgery, hysterectomy, C-section, appendix can affect one side of the abdomen, but that's still scar tissue that could grow and cause pressure down on your bladder. So all sorts of different abdominal surgeries can impact. Vaginal surgeries can impact. If you've had a sling before, or you've had a mesh, or you had a vaginal hysterectomy, those things can also cause scar tissue, which can either weaken the pelvic floor muscles or cause pressure from above and scar tissue. What else was I going to say? So Dr. Kegel was a physician in the 1930s. So Kegels have been around for a long time. And in the 1930s, he decided that if women strengthen these pelvic floor muscles, they would get strong enough to maybe not leak so much. So Kegel is just a general term for pelvic floor contractions. Makes sense to everybody, I'm hoping. So when you do a pelvic floor contraction, it's hard to know. I've been asked, how do you know if you're doing it correctly? And that's kind of hard if you're just standing around or sitting around. But if you're doing a pelvic floor contraction correctly, nothing should be moving that anybody sees. You shouldn't be sucking in your belly. You definitely shouldn't be squeezing your butt. I see people that are squeezing their legs together or doing all sorts of weird movements to get a pelvic floor contraction. You're just basically you're contracting these inside muscles. They have nothing to do, the butt's out here, belly's up here, legs are down here. None of that is what you want to contract. You're just contracting here. You're just pulling your vagina and rectum up inside you. The ways to be able to tell if you're doing it correctly, you can put your own finger inside your vagina and see if you feel the sidewalls contracting. During intercourse, you can squeeze your partner. If you're weak enough, they're not going to feel you, but if you're strong enough, they will feel you, and they can give you some feedback as to whether you're doing it correctly. There should be no pushing out of the pelvic floor. If you're feeling your belly push out as you're doing the contractions, you're probably doing them wrong. Everything should kind of pull in and up. They've done studies that have shown that about half of the women tested were doing them incorrectly. And of those, half of them were doing them so that they were getting weaker instead of getting stronger. They were pushing out and bulging the muscle instead of contracting it correctly. So if you really don't know how to do a pelvic floor contraction, you probably need to work on it and make sure, or come see. Although people don't realize it, there are quite a few of us around that are pelvic therapists. What I tell my patients, once they know how to do a contraction, then we start working. We start in lying down, so if Mabel's lying down, there's no gravity working on her pelvis, no gravity working against her pelvic floor muscles. As soon as she either sits up or stands up, gravity is going to pull down. So I have most of my clients learn how to do pelvic floor contractions or Kegels in lying down. Once they're strong enough, we then progress to standing up activities, because that tends to be when we leak. So what we do is we work on contracting and pulling up on the pelvic floor. And the cue that I give people is imagine that you are picking up a raisin with your vagina. It's soft, it's squishy, it's lightweight, and it's even a little bit sticky. So it's going to stay where it's supposed to be. I've heard other people that use blueberries as their imagery. To me, I imagine picking up a blueberry with my vagina, and I would just squish it and there'd be blueberry juice everywhere. So I like the image of a raisin. I gave a talk like this to a group, a MOPS group. Does everybody know what MOPS is? Mothers of preschoolers. And we talked about, I talked about pelvic floor strengthening. And the first year I just talked to them. The second year they had me come back and they had a little box of raisins at everybody's place, which I thought was pretty cute. But I had to stress, do not use these. This is just imagery. So the reason I want to use an image is because I want to think about picking that raisin up and then not dropping it, but putting it down gently. And then picking it up and putting it down gently. And again, I should be able to do that standing in line at the grocery store and nobody sees anything moving, because I'm not using my butt or my belly. So that's how I kind of talk about doing a pelvic floor contraction. I'm guessing no questions at this point. Everybody's kind of following me along. You do use some of your lower abdominal muscles. There's a group of muscles that go across the very lower part of your belly that are called the transverse abdominis. I kind of relate them to being a seatbelt because they're going across. Those deep seatbelt muscles are going to contract when your pelvic floor contracts. Nothing's going to move. They're just going to kind of pull in just a little bit. That's part of your core, and they contract together. The other muscles that contract at the same time are little muscles that go down and attach each of your vertebrae together. So when you're talking about core, you're talking about the lower abdominals and the low back. If that was all it would kind of be like a ketchup bottle. We'd squeeze and everything would come out the bottom. So there's the pelvic floor supporting it at the bottom, so that you're a canister with support at the bottom. and there's other muscles going on up top, but the real core is that. So when people are doing crunches or sit-ups or those kind of activities, you're strengthening your abs, but you're not really working your core. Your core is the deeper lower muscles.
I have a question.
Yes.
To find out where your Kegel muscles are, does it matter if you think about it as when you urinate, trying to tighten your muscles to keep the urine from coming out? Does that kind of let you know where they are?
It does let you know where they are. There's some places say to do that as your form of exercise regularly. I now say don't do that, because if you do it every time you urinate, your bladder could go into spasm. It doesn't know if it's coming or going. So, but I do tell my patients, you can try and do it like once a week, twice a week at the most, just to kind of get an idea. So every Monday morning, am I doing this correctly? Am I getting stronger? And as you stop your pee, right now, I mean, initially, if you're weak, you may not see any change. Your flow may just keep flowing.
Mm-hmm.
As you get stronger, often your stream will shoot forward in the toilet. So it'll kind of be like you're aiming for the front of the toilet. That's because in general, for most of us, the back muscles around the rectum are thicker and stronger. So they're going to kind of push that urine forward. But it does mean you're doing the correct exercise.
Okay.
Correct movement. As you get stronger, you should be able to close it off completely.
Wow. Okay. Thanks.
Does that answer your question?
Yes, it does.
All right. Where was I? Talking about the core muscles. One thing I was going to say that sort of is an aside, if you've had a C-section, you should never, ever be doing sit-ups or crunches. They're finding that, and I don't think most people realize that cut into your abdomen is going to weaken and cause issues, as you can imagine, to your uterus, and that you should never be then doing crunches. There's lots of other core exercises you can do, planks, and there's other things you can do, but not crunches or sit-ups. So back to incontinence. Sometimes what happens is the bladder itself gets real irritated. And that can be from the pressure from something else, that can be from a disease, that can be from frequent urinary tract infections. There's all sorts of things that can impact the bladder. If you drink a lot of caffeine, if you drink a lot of citrus, if you drink a lot of wine, all of those things are bladder irritants and known to be bladder irritants. So if your breakfast in the morning consists of a glass of orange juice and a cup of coffee, all you've got in your bladder is something that's going to irritate it. So you may well need to empty it. You probably have heard you should drink 6 to 8 glasses of water a day. And that's one reason, is to dilute the other things that we've been doing. We now say instead of 6 to 8 glasses of water a day, you should drink half your body weight in ounces. So if you weigh 150 pounds, you should be drinking 75 ounces of water a day. That's a lot of water. And a lot of my clients that have incontinence cut way back on their water intake because they think that that's going to help. Actually, it's the reverse, because if you're not drinking the water, what you are drinking is just irritating your bladder. And everything's concentrated. When you pee, it should be really light colored, almost clear. If you're peeing dark yellow, you're not getting enough water. So if you've got something that's irritated the bladder, whether it's the caffeine or UTI, whatever it might be, you may be having urgency and frequency. They kind of can go hand in hand, or you can have one or the other, where you're frequently urinating or just feel the urge to urinate a lot. One of the things about frequency is we kind of learn really young to empty our bladders a lot. Soon as we're leaving the house, what does mom say? We're going on a car ride, everybody go to the bathroom. They refer to that as jicking, going just in case. And we've trained ourselves and our kids really young to do that. We're heading out to the store to go grocery shopping. We go one more time to the bathroom, even if we just went 15 minutes ago. So if you cannot train yourself, if you can start delaying it, if you know you just went 15 minutes ago, you shouldn't need to go again. So trying not to make a habit for your bladder to empty when it really doesn't need to. And bladders can become very susceptible to those habits. A lot of women will have no trouble all day long. People like teachers, nurses that don't have an option of going, they'll do great. And then they get home, they put their key in the door, and they can't make it to the bathroom. All of a sudden, or they drive into the driveway, and all of a sudden they've just got to go. They actually refer to that as latchkey incontinence, because it's as soon as your key hits the door. That's just a matter of you've trained your bladder that you've got to go then. It isn't any worse than when you left work 10 minutes ago. It's just that you've trained that bladder. So bladder retraining can be an important component to learning how to stay dry. Because once you've got that sudden urge, sometimes there's nothing you can do about it. Am I missing questions? I see chats at the bottom. Are they questions or comments? Let me see what it says. Wish I knew this before I had kids. Yeah, I know it. In aerobic and I don't know that people are aware of how much crunches can injure that abdomen. So trying to find another exercise for people, and sometimes that's not easy. Okay, moving on. That was kind of everything I was going to say about incontinence itself. Is there anything anybody has a question about as far as that goes? Nope. Okay.
I did put, Linda, I did put a question. How long does it take someone to retrain their bladder if they have like a latchkey incontinence, which I think I have, because at work I hold it all the time because I'm always running to meetings. So how long does it take to retrain?
It's like just about anything else in the medical field. It really depends on you. Everybody's individual. So when I get to kind of the treatments that I'm going to talk about, there are some things that you can do to help retrain. So how quickly you get better is going to depend on how often you do the exercises, how weak your pelvic floor is in the first place, how much of a habit you've established, all sorts of different things like that. Does that make sense? Okay. Prolapse. So prolapse is the organs, here I'm back to Mabel, the organs in your body kind of coming out through the vagina. It can be the bladder, it can be the uterus, it can be the vaginal wall itself, it can be the rectum. Any of those can kind of start weakening and sliding down. If your pelvic floor, which is a sling from the pubic bones to the tailbone, if that sling weakens, it's going to kind of droop. As that droops, it's not providing the same support for all of your organs that are there, that come out there, uterus, bladder, and rectum. There's an angle to the bottom. So the bladder is here, and then there's the urethra that comes from the bladder out to where you're peeing, and that's got an angle to it. If your pelvic floor is weaker or droopier, that's going to lose the angle. And then gravity is just going to do its thing. So that can be one cause of prolapse. The ligaments that support everything hold your uterus up, like I said, that's where a lot of ligaments are. The vagina itself has quite a few ligaments that are supporting it. If those ligaments get damaged during childbirth, get damaged during a hysterectomy, and damage during a hysterectomy for especially the ligaments around a uterus, imagine, okay, so here's your uterus and here's all these ligaments, they're going to cut those. So you're suddenly not going to have the same support. And those cuts are going to cause, so if you've got your ligament from your uterus back to your low back, your sacrum, and that's now been cut, that's going to cause a scar that's going to go to someplace. And so the ligament support, if that's not there for a variety of reasons, then those organs are going to start sliding out also. That's also a reason for the like anterior posterior vaginal prolapse. The walls of the vagina, if they aren't being held back, they're going to start falling in. Does that make sense? I'm doing a lot of handwork. Everybody's still following me. I've still got everybody with me. Often prolapse and intercourse go together. If the muscles are weak enough that things are prolapsing, they're probably weak enough that you also are having bladder control issues. Or incontinence can also include fecal incontinence. I see quite a few women who their episiotomy or their tear, it wouldn't be an episiotomy, it would be a tear, goes from vagina all the way back through the walls of the rectum, the sphincter of the rectum. That would be a stage 4, level 4 tear. And that can cause all sorts of issues with bowel incontinence. Again, we're going to treat it very similar to the way I'm going to treat bladder incontinence or prolapse, with strengthening of the pelvic floor muscles. There also, if there was a tear that far back, then the rectal sphincter itself can have scar tissue. And if it's got a major tear through it, it's not going to want to close the way it's supposed to. So I kind of went backward into incontinence, but kind of, again, goes along with prolapse. Some women, the rectum can prolapse into the vagina so that they can't have a bowel movement because there's a kink in the rectum in toward the vagina, and they need to actually put a finger inside their vagina every time they want to try and have a bowel movement. That can get stronger, but usually if it's that bad, you may need to see a doctor. I can treat some of it, but it depends on the level and the severity.
Can you explain that again, please?
Which part of that?
What would require you to have to put your finger in your vagina to have a bowel movement?
So if your rectum, or the bottom part of your colon, is prolapsing, is starting to sag, it can fall into the vagina. So there's one thin wall, there's the bladder and a thin wall and the vagina, and a vagina and a thin wall and the rectum. So if the rectum's starting to prolapse, starting to sag, it's going to push against that wall of the posterior wall of the vagina. If you've got two tubes and it starts pushing in on the other, then you might have trouble having a bowel movement, because now instead of being up and down, this wall is going this way. So you've got to put a finger inside the vagina and push this back up to be able to have a bowel movement. Does that make
all of this
sense?
It's helpful because I just had an appointment yesterday with a urologist, PA, and talking about incontinence and constipation for me, and trying to understand it. And your explanations are making so much more sense because it's clear in my head what's happening inside. So thank you.
Constipation is a huge contributor. Constipation is a huge contributor to incontinence. If you're pushing down every time you have to have a bowel movement, your pelvic floor muscles are just going to get weaker and weaker. You should not need to push out your bowels or bladder.
And does that, go ahead, finish your thought.
What were you going to say?
They said my bladder is thickened. Might that be why my bladder has a thickened wall?
It could be, I'm not sure. It could be that you've always had a thickened bladder wall, a thicker bladder wall. I don't know. I haven't heard that term before. One of the things I do know as far as bowel movements go, we were not designed to be sitting up straight to have our bowel movements. You may have heard this before. The new sort of squatty potties became the in thing a few years ago. What a squatty potty does is put us into a squatting position, which is the position that our body was made to have a bowel movement in. Our rectum does not go up and down, it's at an angle. So if you're squatting, you're going to put yourself down in that correct angle. In countries where they squat, as opposed to us first world countries where we sit upright, they have much less problems with their pelvic floor.
Mm.
So I can show you what a squatty potty is. I keep one in my office. This is a squatty potty. So it actually has your feet angled very slightly so that your heels are just slightly above your toes. And it just sits or goes around the toilet. And it puts you down it puts your body in a squatting position without you actually squatting.
Oh,
And
you're putting your feet on top of it in front of the toilet.
so that you're down in that squat position.
Okay.
I have some people that just use regular stools, and that can help. You just need your feet kind of wide apart. So if you've got a stool in front of you, you're not going to get that feet apart side.
Got it.
That's what the squatty potty provides.
Okay.
And I have a lot of women that squatty potties really help their constipation because it gives you that correct angle. The other
Where
thing,
do you get those? Are they pretty easy to pick up somewhere?
Costco.
Okay.
I don't know if they still do. Our local hardware store used to carry them. I don't know why, but they don't anymore. Oh, somebody said
I see that, Bed Bath & Beyond. Thank you.
Okay. The other
Great.
thing that can help constipation is drinking more water.
I do drink a lot. Yeah.
Okay. If your stools are really hard, there's not enough moisture in them, and your bowels are what reabsorb all the moisture. So does hopefully that answers Daphne's question. Anybody else have a question about bowel constipation? We're good? Okay. Last topic I was going to talk about, I was going to go over real quick, the risk factors for prolapse. One of them is older age, menopause. Because the muscles are getting less estrogen, they're getting less blood flow. Family history, if you have a family history of prolapse, you may be more prone to ligament laxity or ligament issues. Increased body mass index, so overweight, you've just got that much more pressure on the organs. Number of births, if you've had a whole lot of kids, you've done some damage to your pelvic floor at some point during that. Or if you have a baby, they consider a large baby that can cause issues to be over 8 pounds. 8 pounds, 8 ounces is considered, over that is considered a large baby. A vaginal delivery, an episiotomy, forceps delivery, constipation is definitely a risk factor, and a really long second stage of delivery. So pushing, if you push for a really long time to get your baby out, you're going to weaken that pelvic floor and you'll be more likely to have prolapse. So my last quick topic, is pain with intercourse. And that can also come with menopause. If you've got less estrogen, you've got less blood flow to those muscles, they're not getting the same moisture, they're going to have, there could be pain. If it's just less moisture, lubricants, there's all sorts of lubricants out there. My favorite is just coconut oil. You can get it anywhere. It works really well. It works well on all sorts of, it moisturizes your skin, it can moisturize your hair, it can moisturize your pelvic floor. And not only that, it's edible. So, we'll just leave that there. There can also be pain with intercourse from other things, scar tissue. Prolapse, there's an actual so the technical term for pain with intercourse is dyspareunia. And there's one type of dyspareunia called bump dyspareunia. And that's where your spouse is actually bumping your bladder, your uterus, whatever it is that may have prolapsed. And that can be painful. So looking at the why, where is it that intercourse is painful? Is it pain just around your C-section scar or your episiotomy scar that's been fine for years, but now suddenly it's tender? Well, your body's changed a little with menopause. Did something else happen to your pelvic floor? I see a lot of women, I see women with painful intercourse that had rectal cancers. And at some point in their life, they had radiation therapy to their pelvic floor. So those burns cause scars, and that's going to make intercourse very painful. They've also, if they've had a cancer, they've probably gone through an immediate menopause. because during their radiation, it zapped their uterus, zapped their ovaries, and they've got no more estrogen in their body. So menopause for some women can happen very young in their life because of that. Let's see. I think, considering what time we've got, that's probably enough for me to say about painful intercourse, unless somebody has a specific question for me. We're good? So what do I do? I'm a pelvic PT. What am I doing? If any of you have ever had PT before, you know that in general, physical therapists work on muscles and joints. People seem really surprised that there are PTs that do what I do. But if you think about it, I'm just still working on muscles and joints. They just happen to be the muscles that are within the cave of your internal body. So I'm going to do a lot of what other PTs do to other parts of your body. I'm going to work on strengthening things. We're going to work on exercises that are going to make those muscles stronger. We're going to work on picking up the raisin and gently putting down the raisin. We probably aren't going to do the same number of repetitions that somebody might be doing on another body part, but we're going to work on getting those muscles stronger. I'm also going to do manual work on any scars that are in there. If there's scars within the pelvic floor, I'm going to work on loosening those scars up and do some scar tissue release techniques. When I first see a patient, I'm going to evaluate the strength of their pelvic floor, whether they're coming in for incontinence, prolapse, or dyspareunia. I'm going to test the strength of their pelvic floor. If they've got dyspareunia, I may be much different in how far in I go and how much I do an evaluation, because I don't want to make it painful. But all I'm going to use is my finger to do the evaluation. So if they're having pain with intercourse, chances are my finger, we hope, is much smaller than their partner. So it shouldn't be as painful. If it's painful, I'm going to back right back out, or I'm going to work on I'm going to find out where that pain is and avoid that area and work on other areas to loosen them up, and then go back and work on that area. Does that make sense? I kind of skipped around there a little bit. I'm also going to work in the abdomen itself, in the belly, and make sure that the bladder's moving correctly, that if they still have a uterus, that's moving correctly, that they can glide against each other. I'm going to make sure that if there are any scars, because very often people won't tell me about their scars that happened when they were a kid. They won't tell me about that appendix burst that they had as a kid until I'm looking at their belly and there's a whole lot of different scars. And we start working on those scars. One of the other areas that I tend to work on is the diaphragm, right up under here. If the diaphragm is tight, it's going to be pushing down on all of the organs, which are going to push down on the pelvic floor. I worked with one therapist who says she only works on the diaphragm on her patients that breathe. So I've started doing that also. And how many of us breathe? Oh, that would be all of us. So I need to loosen up the muscles way up high in your diaphragm. Those muscles actually blend with your hip flexors. The diaphragm and the hip flexor muscles meet along your back. So if you're having trouble in the lower pelvis, in those hip flexor muscles, you may well be having trouble and painful muscles in the diaphragm. And the diaphragm is a huge muscle that people often don't think about strengthening or releasing. Sometimes it's just a matter of some sort of trauma has happened to the pelvic floor. And that trauma is surgery. That trauma can be childbirth. That trauma could be trauma. That trauma could be somebody that's been abused at some point. Any of those things can kind of cause a shutdown in our brain so that we aren't listening to our pelvic floor or aren't addressing our pelvic floor. We've kind of cut it off. I'm finding sometimes I just need to wake up that pelvic floor muscle. Wake up, especially a part of it that might have a scar in it. Get it to able to contract again. I had a woman this week. She just couldn't get that pelvic floor to contract until I just did a little bit of work, and suddenly she could contract it. So sometimes it's just making a connection between the two. Somebody had a question that I said I was going to answer. Did I sort of answer it on how to, was it you, Diesta, that had a question in the beginning? Did I answer that? Okay. That sort of sums up all of the information that I was going to throw up at you. I kind of do a lot of talking, a lot of information. What have I made you confused about? What have I not answered? What questions do you have?
I have a question. This is Belle. So I had my appendix ruptured. I didn't get surgery or anything, but I was in the hospital for 10 days. Would that have, and apparently there's just a very small, tiny bit of my appendix that's left over. Would that have contributed to urgency issues?
It could. So they didn't do any, they didn't remove your
No, because it ruptured, so it already had.
But they didn't even need to go in and clean out what?
Well, it got really infected, so that's why I was in the hospital for 10 days. So I was just on antibiotics. But they after quite a few months, they took another CAT scan because it was so infected they couldn't see anything. So we had to wait a lot of months to see what was left, and there was just a little bit left. So it had already ruptured. So they couldn't do surgery, right? Because it was too late by the time it ruptured. So
it's possible that that's caused enough scar tissue to be pushing. So, and your issues at this point are incontinence?
More urgency, not stress incontinent.
Okay. So it could be that. It could be, how long have you had the urgency since the rupture?
I think the rupture happened, I think, about 5 years ago, and the urgency issue has become more of a problem in the last 2 years. And I'm 55 now. Okay.
So I'm wondering if it's more habit initiated, or something irritated your bladder and you then are now just constantly trying to empty it, and that can be, it's hard to guess, but that would be, I would think it could have been related to the rupture, because that could irritate, that could have been this initial cause of irritating your bladder. Without seeing you, it's hard to know exactly, but I would say it's either that, or it's amazing what our head does to the rest of our body. Somehow you've gotten used to at one point you got used to emptying your bladder frequently, and now it just wants to keep emptying frequently.
Yeah, and then I'm just curious, is prolapse the same as atrophy? When people talk about things atrophying, is that the same thing?
As prolapse, no. Atrophy is just the muscles being so weak that they have gotten smaller.
Oh, okay, because when I saw my doctor, she's like, oh, there's a little bit of atrophy here. So
the muscles have just sort of shrunk in size. So think of your biceps. So if somebody's a real weightlifter, right, their bicep builds up in size. Then if that muscle doesn't get used at all, it's going to atrophy and get smaller.
And so Kegels will help with atrophy?
They should, definitely.
Okay.
And they should help with urgency. Oh, that was one thing I was going to say. That's what I was going to talk about. If you're having urgency and you know how to do Kegels, so you just went to the bathroom, but you're running hot water and you're doing the dishes, and suddenly you feel like you have to go again. Try and relax and do a couple of Kegels. If you're able to just go sit down someplace, do that. Just completely relax your body and just do some Kegels. What happens is both your bladder and your pelvic floor are innervated by the same muscles, and they cannot contract at the same time. So if your bladder's trying to contract and you can relax and contract your pelvic floor, then your bladder should relax a little bit. It's hard to do if that happens and you are somewhere like the grocery store. So I always suggest do it at home. If you're getting that urge, just try doing a couple of exercises, just a couple of Kegels. They don't have to be long, whole lot of repetitions, whole lot of hold, whatever. Just pick up that raisin a couple of times and put it down. That should calm down your bladder. so that you can walk through the house if you just got home and put the key in the door. That was the question, Diesta, and I almost forgot it. So if you're having that and you stand at the door, it's hard to relax. I will say it's really hard to relax when you feel like you're going to pee your pants. Relax, take some deep breaths, do a couple of Kegels, and you should be able to walk like a normal, sane person without tearing your clothes off, get to the bathroom, and go then. So, Belle, that might help the urgency. It might help Diesta's latchkey. That it's a huge way.
That definitely helps. That definitely helps me. And I found that I consciously have to try to relax my stomach because I get I'll tighten that. So I consciously relax that. But are you saying sitting down could also?
Well, sitting down just helps your whole body relax more.
Okay. Because sometimes I feel like I'm having to Kegel or hold those muscles tight in order to, not go pee. And so I was just wondering if I sat down, if it would relax so much, it would.
One of the things that we tend to do, even as little kids, if we have to pee really bad, we cross our legs and tighten every muscle in our bodies.
Right.
So it's really counterintuitive to relax.
Okay.
Relax your belly, relax your legs, don't cross so hard. And it's a hard thing to do when you've really got to go.
The other thing I was just going to ask is that my doctors don't think this is the case, but I had fibroids, and so we looked at 5 years ago or so when I was in the hospital. I had 4 or 5 CAT scans, and they say my fibroids are about the same size. They don't think so. My doctor doesn't think that's what's contributing, because they thought, well, if we have to remove your fibroids, my doctor said we're going to have to remove your whole. I'll have to have a hysterectomy, basically. She was worried about all the scar tissue. I don't know, something like that. But I'm just hoping it's not the fibroids are just saying they didn't seem to have grown in the last, since the problem happened after the hospitalization. It seems the fibroids are the same size, about a little bit larger.
So it depends on if a fibroid's huge within the uterus, then it's going to push on the bladder and cause urgency. If it's not any bigger and that's been there for 5 years and you've only had the urgency for the last year or two, I would have a hard time relating the two.
Yeah. Okay.
Yes, to just ask me how often we should do Kegels during the day. If you're just working on strengthening, if somebody comes in to see me for pelvic floor weakness and we're going to work just on strengthening, I just have them start with twice a day, and we just work on how many they can do and not any more than that. Once you get strong enough, so if they can do 3 5-second holds, then we're going to do 3 5-second holds. If they can do 5 quick contractions, they're going to work on 5 quick contractions. As they get stronger, the idea is that you're going to contract your pelvic floor all day long doing anything else you're doing. Every time you stand up, every time you pick up something heavy, if you've got yourself trained right, you're going to work on contracting the pelvic floor instead of pushing out on it or doing something else. So you're going to eventually be at the point where you're just doing them all day long with just as much as you're using your legs to walk. But to start with, we've got to teach you how to use the pelvic floor correctly. Coconut oil is a lubricant inside the vagina. It can go inside the vagina. There's nothing wrong with that. Just sort of using it around to lubricate whatever you're going to need lubricating. It can definitely go in. You don't need it it's not going to be all the way up, but yeah, you can definitely lubricate. And my doctor, actually, I had my annual checkup last week, and she said, am I still using? So what I used to use was slippery stuff. And that's what I use sometimes as the lubricant. It's what I used to use all the time as the lubricant for my evaluations. Just put some on my finger to do the testing. But so now I use coconut oil. So she said, are you still using slippery stuff? And I said, no, now I'm using coconut oil. So she learns from me what to tell her clients to use. But she had some of the same questions. Do you just sort of drip it on there? Usually, if it's cool enough, the slippery stuff is like semi-solid. When it gets warm in the summer, it gets a little bit more liquidy, but you can just scoop it onto your finger and put it where you need to. Does that make sense, hopefully? Other questions? I'm kind of looking at the list, but seeing if anybody has a question, they're welcome to unmute themselves and ask me. hopefully I gave you some information that you can use to take forward. Hopefully, if you're having a big enough issue, you can find a pelvic health therapist near you. I know there are us in Tacoma and Seattle and, you know, most of the big cities. It's probably unusual that I'm in a little teeny town in Enumclaw, but even in this little small town, I can stay pretty busy treating. Well, right now there's an awful lot of women getting pregnant, so I'm busy with that the most. All these COVID babies. Yes, Betsy.
So if I have painful intercourse, and I know that my bladder has dropped, then that's probably what is causing that. I mean, I see, as you went through this list, I'm going, yep, yep, yep.
Does it feel like that's what he's doing? He's bumping into you, then that would be why.
Okay.
So it may be, have you had abdominal surgery of any sort?
No, no, I have no estrogen because I'm on tamoxifen, and I have been for almost 10 years. So that's going to come to an end.
Okay.
I don't know if that means that my estrogen will come back. I don't know.
Probably not much.
Yeah. And I'm 68, so
that
it's,
was to
you
kill,
know,
get rid of all your estrogen, right? That
right.
was
Yeah, it's an estrogen blocker.
yeah.
So I'll do so many of the things that you were talking about. The rectum, I have notes. That's why I'm looking down, looking at myself, looking at my pelvic. No, I'm looking at my notes. Is that the rectum prolapse? I think I might have that. I mean, I'm just looking at this going, yeah. And so I'm the coconut oil, I'm going to try that because I use coconut oil all over my body. So might as well use it in there too, I guess. So anyway, I guess that's
Might need to find a pelvic therapist that could help you.
okay. Yeah, and I can call the office for different like for insurance and that type of thing. If it's covered. I can do all that later. We won't do that here, but
Somebody asked if I'm taking, Diesta asked if I'm taking new patients. Yes, you might not get in for a couple of weeks. I have no idea if coconut oil stains sheets. I don't know. I've never noticed stains, but I'm not sure. But I am taking new patients. I know I'm in about the middle of October right now for new people. So I would be glad to see anybody that needs help. Again, I'm kind of far away from anybody but I see people, I have people come to me from Puyallup and from Renton and from different areas. So I can work with you. If it's a long drive, see you once, give you some ideas of something to do, have you come back in a couple of weeks instead of every week or more than that. Did I get all the new questions? Well, I'm glad Daphne thinks I've been helpful. Thank you. No more questions from people. I'm not getting anything else. I'm sure Diesta's got my contact info because she called my office.
I have a question. I'm thinking
Therapy. I tried to come up with a name that would we're the head of the family. Also, an F is going to put me way toward the beginning of the alphabet. So I'm going to be one of the first PT clinics that you would find if you were looking at PT. But nobody else, most regular PT clinics aren't going to treat any of this. You're going to come in and they're going to say, no, thank you. I don't go there. But there are some of us around that do.
Can you tell us, so I was just recently started to use the estrogen cream for the urgency issue after the last talk where the doctor suggested I try that instead of the suppositories. Can you show me on the model where I should be putting that cream? Is it right at is it the urethra or where?
Urethra is the little teeny tiny opening just under the, just at the start of your labia. So there's a little teeny opening there, and that's where the urethra comes out.
And so is that where I should be putting the estrogen cream?
Probably some there. I would think vaginal more.
Okay.
That would just be my guess, would be more vaginally. It's going to get absorbed into the bloodstream, so it should go to other places as well. But I think generally the estrogen cream is supposed to be put vaginally. That would be more of a question for the doctor for sure. first.
I know my doctor told me to put it vaginally, and I have kind of a, you know, suppository that you use to push it up there. So that's where I've been told to put it.
Yeah, so, okay, so I have a suppository tab, but then you know, from the last your presentations, that the director from the Portland clinic said to maybe try putting it on externally on the vagina. So
Yeah.
I'm thinking she meant sort of in that, she said the inner layers of the labia or something like that. So I'm just.
Yeah, the labia lips just sort of surround everything. And then within that, you've got where the urethra comes out and then the vagina. So just sort of.
Put it up there.
And what does that do? So what did the estrogen cream do?
The estrogen is going to help increase the circulation again, increase the blood flow to those muscles so that the muscles are going to be able to function a little bit better.
Okay, thank you.
Well, if there's no more questions, I'd love for everyone to come off mute so we can give Linda Hassenauer a round of applause for today. At 1, 2, 3, let's give her a round of applause. She was amazing.
Linda, that was so good.
Yeah, really helpful.
Thank you.
And this is life-changing, Linda. This information is life-changing for women. I wish I would have known this 30 years ago.
You know, I do too.
Yeah, I had a full tear all the way from my vagina all the way to my rectum, and I had so much scar tissue and so much pain.
Well, and you probably still have all that scar tissue.
I do, and so this has just been so insightful for me, and you know, just things that I can apply right now. So I just want to say thank you so much for your time, your Saturday morning. We really appreciate you and want to have you come back, and this has just been great. So thank you. Do you have any closing words, Linda?
It's the pelvic floor is just another part of our body, and we really need to be aware of it. And I think that's probably, it's just part of our body, and we should treat it as such and take care of it.
Yeah, it needs attention. Okay. All right. Thank you, everyone. You'll get the replay probably this evening. If you missed anything, you can go back, and she said some things that were just phenomenal that I wrote down, but I'm definitely going to watch it again. So I just want to say thank you, everyone. This is the end of our Doc is In series, but your last email will have the links to all of the previous events. And so I just thank you for your support. It's been wonderful.
Thank you for organizing.
Yes, that's been great. Thank you for putting this together.
Yes, thank you so much for this opportunity.